Okay, well, thanks for having me. This is a great topic to talk about. It's something we talk to our patients about a lot, and it can be a source of real frustration for a lot of our patients. And so I think, and at the same time, I think that there's been a lot of really great work, especially done by the CAGLA group in this space. I think there's a lot of really great work that remains to be done, and I'm looking forward to working with all of you on that. But thank you for having me. I look forward to talking to you. So my disclosures, I am on the Speakers Bureau for AstraZeneca, and I'm also a consultant for Merck. And again, I don't think that will influence anything I really have to say to you today. So talking a little bit about gynecologic cancers, cancer and reproductive options. So I just want to talk to you guys briefly about what your reproductive treatments or what your reproductive options are and how cancer affects the GYN system, the reproductive system, and your treatment options, and then talk a little bit about how we might preserve fertility and reproductive function. And then also, this is all very timely, review some of the recent reproductive legal landscape events in our state and our region, because a lot has happened recently. So we have a lot of reproductive options. There's many paths to parenthood, everything from taking care of your cousin's kid to high-tech IVF with pre-implantation genetic diagnosis. So there's many ways to be a mother and a parent. All of them are expensive. Turns out once the kid gets here, they're still expensive. So I'm learning that because I have a 4-year-old. So you might as well get used to that part. But they're all pretty expensive, both in terms of financial and then obviously emotional, mental energy. They're little leeches, but they're cute. All right. So specific gynecologic cancer consideration. So we heard a lot about breast. My day-to-day is taking care of gynecologic malignancies. And the cool thing about that space is that we're very comfortable talking about reproductive options. And so I think we've done a lot to maximize fertility options for patients within the capabilities of what we have at our fingertips from a scientific standpoint. There are many barriers to getting that care, which we can talk about towards the end of the talk. But there's a lot of stuff we can do that's really cool. Even when you get cancer of your reproductive organs, you can still often proceed to have a child. So cervical cancer. So this used to be our most common gynecologic malignancy, and in under-resourced countries, it remains very common. We see a lot more of it down here than we do in other parts of the country. I trained again in Baltimore and Cleveland, and I think I saw more cervical cancer my very first day of work here than I saw in my entire training before coming here. So I think first and foremost, prevention needs to be stated. So when people think about things like vaccines and pap smears and follow up on those pap smears, the best way to not have a cervical cancer prevent you from having children is to not get it. So get your vaccines, get screened, all of those things. But we are really good at catching cervical cancer early in this country because we have well-established screening programs. And Louisiana actually does pretty good in getting women to screening. I think a lot of times where we fall out is what happens after the screen is abnormal and getting people to timely and effective care at that point. But if you have a cervical cancer that's detected by pap smear, which is usually how we detect it in this country, and we catch it early enough stage, we can often do things that would be amenable to retaining your uterus. So you can do things like a cold knife cone. So we do those all the time. It's one of the ways we diagnose and treat cervical cancer. And it's basically, you see a little picture there, we just take a knife and we core out the bottom of the cervix. Well, if you have a really early cervical cancer with low risk features, that might be all you need. And you can go on and have children. There is some association with preterm labor, preterm delivery, things like that. But the vast majority of women that have that can go on, get pregnant, carry full-term pregnancies, and have really healthy children. So that is an option for people and a good argument for screening and for early preventative care. There's this really cool procedure called a trachelectomy, and radical trachelectomies are not common. Most GYN oncologists probably do, a handful in their careers. They're not common at all, but they're very neat. I have done them. They're very cool. What you do is it's like a radical hysterectomy, which if you don't know what that is, it's a normal hysterectomy, but then all the stuff around the uterus, we take that as well. So instead of taking your ovarian vessels that feed the uterus at the top, we leave those, we leave the ovaries, we leave the top of the uterus, and we just do like the bottom part of a radical hysterectomy. So we take the cervix and then the tissue sort of around the cervix and the part of the upper vagina. And we usually do a lymph node dissection with that. We do something called a cerclage, where we just basically take a piece of real tough suture and just kind of pinch the upper cervix, lower uterus shut. And then we sew the uterus to the vagina, so you no longer have a cervix, okay? And those patients can, in fact, go on and carry pregnancies. The pregnancies are extremely high risk, and there's lots of considerations about that we'll talk about, but that is an option. And then I talked about lymph node dissections. There's no reason doing a lymph node dissection would prevent you from having children in the future. It's just a pelvic surgery to remove lymph nodes. We do see a lot of locally advanced disease, especially in patients who present the other way, so the patients that have not been screened but come to the emergency room with bleeding and things like that. Those patients are often not treatable with surgery, so we can't do a trachelectomy or even a hysterectomy and leave their ovaries behind. They need pelvic radiation. So one of the things that we can do, which we'll talk about, is ovarian transposition, and I've done that a number of times, and you just basically take the ovary, detach it from the uterus, and you pop it up someplace out of the radiation field. The benefit of that is really twofold. Like, one is for fertility, but two, ovaries are great, right? If we were talking about male reproductive cancers and I was just like ripping testicles out of men, people would be appalled, right? So don't do that, right? Nobody likes that. So anyway, conversely, some women would really like to keep their, their ovaries and the hormonal function that's associated with them. So reproductive outcomes. So the cold knife cone, as I told you, is associated with a higher risk prematurity. This data is a little bit complicated to kind of interpret. What I'll tell you is it makes sense, right? Your cervix sits at the bottom of your uterus. Theoretically, it probably holds things in during pregnancy, and if I take a piece of it out, it's probably not going to work as well as it used to. But there's been nobody's doing any prospective randomized controlled trials on reproductive women lopping a piece of their cervix out and seeing if they actually carry pregnancies or not. So we don't really know that it's causative. We know there's a lot of correlations. So there are things that are associated with preterm delivery that are also associated with cervical dysplasia. Smoking is an example. So there's a number of things on that list. So it might be just an association. It might be a causation. Either way, it's something we counsel our patients heavily to. But again, the data is very much clear that most of those women will go on and be just fine. Radical trachelectomy is a bigger deal. I can remember delivering a number of these when I was in residency and being involved in their care during fellowship. They need C-sections. They often deliver early. So we're talking like extreme prematurity NICU babies, 24 weeks, 25 weeks. These are important things for me to know about, not because I do obstetrics anymore, because I cannot remember how to do that. But it's important for me to know because when I'm counseling patients to these options, they need to understand that, yes, we can preserve your fertility and you can get pregnant, but we're not talking about like, I'm going to go have a home birth and like a water bath pregnancy. We're talking like you're going to have a really high risk pregnancy and you're going to be watched really closely. And you might have have some losses. Like you might get pregnant and carry to 20 weeks and PPROM and lose your pregnancy. So it's not a very romantic future always, but it is possible. And I have seen live babies born and mothers and whole families, and so it's very possible and it's exciting. So the complications are there. The risks of, the pregnancy rates when people try are about 55 to 65%. It is possible to get pregnant spontaneously. It is not the rule though. And so what's important, I think, and we have these discussions about things like IVF, many of these patients will need IVF to get pregnant. And so they need access to those things as well. So in my practice, when I see a young woman with cervical cancer who needs a radical trachelectomy, the other thing I have to counsel her too is, all right, we do all of this, and what happens if you can't spontaneously conceive? Are you going to want to do IVF? Do you have the means to do IVF? Do you have the insurance coverage for IVF? And these are all real considerations, and I've seen patients move out of state to get what they need to do this. So it's an important thing for us locally. Ovarian cancer. So most ovarian cancer is aggressive and needs radical cytoreduction and chemotherapy. So we're usually talking about high-grade serous, and most of those patients are older. There is a unique type of tumor. It's called a borderline tumor because it's, in fact, borderline, that we see in younger patients. And then there's some rare ovarian cancers like granulosa cell tumors and germ cell tumors that we see in even younger patients. Fertility preservation is an option. You do not have to go and remove the whole reproductive system just because an ovary went haywire. So the usual goal with these procedures is surgical cytoreduction and or staging, which just means removal of all visible disease and then going for the obvious places to look for spread. But fertility preservation is an option for them, and I have seen patients with ovarian cancer and borderline tumors then go on to have normal, healthy pregnancies. Endometrial cancer. So this is our most common cancer, and it's getting worse. So this year, and I don't know if this will shock anyone like it shocked me, but when I was in training, I was taught ovarian cancer is the bad one, endometrial cancer is the common one, but the good one, everyone lives. And this year, just because of the increased incidence and the increase in really high-risk forms of endometrial, especially in at-risk and marginalized communities, endometrial cancer will kill more people than ovarian cancer, which is wild because that has not been the statistic for many, many years. There's probably a lot of reasons for that, but we see a lot of this. And looking at our statistics, this is about half of the cancers that walk through my door are endometrial cancer, and we're seeing it younger and younger and younger. In fact, I have a very timely case on this week, I'm taking a young girl, she's 26, to the operating room for endometrial cancer. And she is not a candidate for uterine and I just got her CT or ovarian preservation. So she's going to lose all of her reproductive organs. And I'm going to get to it, but some of the laws and the political landscape here in Louisiana are going to make it very difficult for her to be a mother in the future. And so I think it's worth considering those things as we think about the work we want to do together as an organization. But about 4% of endometrial cancers happen in women younger than 40 as we get more obese, as we have more lifestyle issues like diet and things like that. We're seeing more and more of it. Uterine preservation is really only recommended for what we call grade 1, stage 1A, non-invasive endometrial cancer, which is fortunately a lot of the endometrial cancer that we see in the younger population. It's a very obesity associated, it's relatively indolent, and what we can do for those patients is we just take them to the OR, we do a DNC, we put an IUD in, 80-90% of the time they go into remission. That's spectacular. You pull the IUD out, and then you tell them get pregnant really fast. And that is where we need access to fertility coverage, because these patients do not typically ovulate the way that, a normal physiologic ovulation cycle is supposed to happen. The obesity really messes with things. That's why their endometrium went haywire in the first place. And so they need help getting pregnant. And so if I tell a woman, you just had cancer, we got you into remission, and now I need you to go get pregnant like that, they don't have the coverage for that always. And so one of the things, and we'll talk about this, we've done some work at CAGLA to cover that, but I think we still have some work to do in that regard. The recurrence risk is high, so they have to be monitored for a very long period of time. Up to half of them will see a recurrence over time, and once they develop that resistance to the progestin, you really have to avoid the fertility preservation options and proceed with surgery. Interestingly, this has really led to a change in how we treat endometrial cancer in general, because we see so many sick patients with endometrial cancer that really need to be optimized surgically before we take them to the OR. So we're doing a lot of work at LSU with like Pennington and people like that to say, okay, you're really morbidly obese, you have a new endometrial cancer, let's work on weight loss with your IUD in place, and then maybe you'll be more fit and your surgery will be safer. And so there's a lot of room for improvement of our treatment paradigms because of this fertility work, but it did all start in the attempt to keep fertility on the table for young women with uterine cancer. And live births have been reported. One of my partners, Dr. Castellano, just I think last year had one of her patients who did this had a baby, so it's very possible. All right, organ preservation options. So it's very confusing. It's always something cryopreservation or something transposition, but we'll break it down. So ovarian tissue cryopreservation is really taking a piece of the ovary and preserving it. There's ovarian suppression, which Dr. Locke talked about using things like GnRH agonists. There's oocyte preservation, which is freezing of eggs. There's embryo preservation, cryopreservation, which is taking an embryo, doing IVF cycle all the way to an embryo, freezing that, which is the most tried and true. And then there's ovarian transposition, and there's some more interesting ones we'll talk about at the end that are really kind of on the leading edge of like pushing what we can do surgically for people. So ovarian suppression, basically GnRH agonists basically suppress the HPA axis, and then you don't recruit follicles, and there's some theoretical and some evidence that might be helpful, and it's minimally harmful. So you have to start it a few weeks before your chemo cycle, and the idea is just to preserve the ovarian function after chemotherapy. So ovarian tissue cryopreservation is a really cool thing. I helped with a couple of these cases when I was at the Cleveland Clinic. I do know that Dr. Prasad and Dr. Williams with LSU are working on getting a ovarian tissue cryopreservation project up at Children's, which would be phenomenal for the kids in our region. But basically, they take a piece of your ovary or an ovary and they freeze it, and later it can be reimplanted back in your pelvis, in your forearm, things like that. There have not been a lot of natural births, or by natural, I mean nothing about this is like really a natural birth, but like there haven't been a lot of live births after this, actually in practice. But one of the cool things about it especially when you're talking about younger people, is that it's not just about having kids, right? We already talked about like what I mentioned about taking the testicles out of men. Like the hormonal function is preserved, and so that's kind of a neat thing about this technique. It's no longer technically considered experimental, but I think it's still very much on the cutting edge of what people are doing. So there aren't a lot of programs out there. All right. Embryo cryopreservation. So this is probably the thing that most of you guys are going to be the most familiar with, because when you hear about IVF, this is what they're talking about. So essentially, you can use a donor or partner sperm. You got that there. You have to harvest eggs in the woman, which is, like all things, just so much more work than it is for the man. And so they get a bunch of shots, and they make a bunch of ovarian follicles. Those get harvested with a surgical procedure, and then they put them together in the test tube. They make a little embryo, and then if they like them, they put them in the freezer. And as long as you're not in Alabama, that's all cool. And then pregnancy rates are pretty high for women under 35. And 17.8 if you're over 42. Embryo and oocyte preservation, it's really when you do decide to have a child and get pregnant, it's more about the age of the woman at the time the eggs were harvested for the embryos or the oocyte at that time. So there's some benefit in getting on this game early. I think culturally there's been a big shift towards these things. And you can perform pre-implantation genetic diagnosis on this, which is a neat but an ethically interesting thing, which basically means if you have, or one of the parents has a genetic syndrome or some sort of gene they want to select for, they can actually do a biopsy of the embryo and basically tell you, oh, you're trying, Tay-Sachs disease is in your family. Okay, these 3 embryos would have Tay-Sachs and this one doesn't, and you can actually select to pre-implant embryos with or without those features. Oocyte preservation. This is getting really popular amongst young women with careers. So when I was in fellowship, everyone was just trying to get this done. You don't need a partner, which is a great thing for a lot of young women. There's a rapid increase in utilization. It requires, again, it's much like IVF in the sense you have to do 2 to 3 weeks of build-up with hormones, and then you go through a procedure and they take the eggs and they freeze them. We've gotten much better at this. By we, I mean the REIs. I don't do this either. But they've done a really great job, and so the vitrification process has really been streamlined, and it has been moved off of the list of experimental to more mainstream procedures, and is usually covered for people who have plans that cover fertility stuff. Success rates are now approaching that of with IVF with an embryo, and the cost is about something in the ballpark of $10,000. Ovarian transposition, again, we do this for people with pelvic radiation. It really should be considered for all women under 40 who are getting some form of pelvic radiation. It's a minimally invasive procedure. It's maybe a little bit bigger procedure than getting your tubes tied. So basically go in with a laparoscope, we detach your ovary from your uterus, and we just pluck it up in the upper abdomen. And then you have hormonal function. The risk, obviously, is that what if the cancer's on the ovary and we don't radiate that, obviously. But the benefit for patients where you don't think that's the thing is that they will not go through menopause too early. And then, of course, they have fertility options in the future because they still have an ovary that's not been radiated. These are some really cool surgical innovations. So when I was at the Cleveland Clinic, I actually got to round on the very first uterine transplant that happened in the United States. I didn't do the case. I wasn't spearheading the team. I was just I was moonlighting as a fellow as the general gynecologist on call, and so they gave me her to round on. It was wild because I've never rounded on somebody who was live tweeting their postoperative course, and people were following. I was like, "How's she doing?" And I went on Twitter, and she was telling everyone. I was like, "Can she do that?" And they're like, "Yes, you can't do that. She can do that." But unfortunately, her transplant failed, but it was a really big learning experience. It was really cool to see what happens when you get a really bright and motivated team together to do something really radical. Subsequently, there have been some uterine transplants, and there have been pregnancies that have happened because of those. And another really cool thing that people do now that's been reported, and I think is taking off, it's very interesting in the gynecologic oncology circles, is uterine transposition. So what they do, and this isn't usually for gynecologic cancers, but if you have a young woman, and we're seeing more and more young colorectal cancers, right? And she needs radiation to the pelvis. Before she gets that radiation, you go and you do, again, all of the parts of the hysterectomy except you leave the ovarian vessels, and you go pop the uterus in the upper abdomen. And you just leave it there, and you suppress their menses so they don't have a period into their abdomen, because that would be uncomfortable, presumably. You suppress their menses, they get their pelvic radiation, you go back for a surgery later, and you reattach everything. which is wild. And there have been babies this way. So it's really radical. They're doing a lot of work on this in Brazil, but at all our conferences, they're doing surgical videos showing it's kind of cool and neat. So I don't know. The future is bright, but crazy. So let's talk about the elephant in the womb. So where are we on a map? So here we are. So this is fertility preservation coverage, and you actually, a lot of the people with CAGLA spearheaded a lot of the efforts for our fertility preservation bill, which was a huge success. Essentially, here we are, we're green, so we're looking really progressive on this map. But basically what this means is that health insurance has to pay for fertility preservation coverage, but it's health insurance, it's not Medicaid, okay? I wanna be real clear with you guys, if we take all the children of Louisiana, most of them are covered by Medicaid. So what does that mean when a kid gets cancer in this state? I don't know. I mean, and so we have some work to do to make these things a little bit more equitable for patients. I want to touch base on the surrogacy laws because I kind of had forgotten about this. I hadn't thought about it in a while. But in 2016, a law passed in Louisiana that says that you can only have a surrogacy contract if you have a heterosexual couple who's married, okay? And you have to use your own gametes. So it has to be a male, like if the man has cancer or the man in the relationship, his sperm, her egg. So that little girl that I'm taking to the OR this week, right? She's gonna lose her uterus. And now she's gonna lose her ovaries because they don't look good on her CT scan. So let's say she gets married 2 years and wants to have a baby and wants to use a surrogate. She can't have that contract in Louisiana because she will not have eggs of her own. Now, there are going to be patients who will be able to get eggs of their own or embryos of their own and harvest those, but she will not be able to do that. So I think there's a lot that can be said about this law and problems that many people in this room probably have with what's clearly the intention of this law, which is to be hurtful to people who are not in heterosexual married relationships. But I think if we're talking about cancer patients, it has real implications for them too. So I think we can all get on the same page that this maybe needs to be rethought, reconsidered, and changed. So this was the first IVF baby, Louise, from London. I just put the king cake baby up there because we were talking about them a lot. It was creepy. But speaking of creepy baby things, there's IVF and Alabama. And I don't know if he's in here, but Nate Jones, yeah, there he is, I see him in the back, was giving me the tea. He's from Alabama. So he was giving me the tea on what the heck is going on in that state. What he said, sharing the gossip, is that, so we all kind of know the backstory about what's going on in Alabama, like somebody dropped an embryo. Word on the street is that it was a psych patient that got out of the psych ward, broke into the IVF lab, dropped the embryo, which is crazy. I just think it's good tea. And then the patients, the people that sued and have created all of this havoc, right, for so many people trying to have babies in Alabama, went on and had children of their own. And so they were able to have their own kids. And there are a lot of people in Alabama suffering right now. So it's just, anyway, I had to share the tea because I like gossiping. And then, so we talked about that. But so I think the IVF clinics are shuttering. These patients will potentially be coming here for some of their fertility care because we're nearby. So we're going to see some of this, and I really hope we don't go down that path with them. I think it's really problematic for cancer patients. And then, let's see, many patients don't have access to, many of our patients don't have access to reproductive strategies, so why try? And I feel like this is a personal challenge. Over and over and over again in my clinic, I see young women with uterine cancer, with cervical cancer, and it feels a little bit defeatist having this conversation with them because I take care of a lot of patients with Medicaid because, let's be honest, we're Louisiana. A lot of our patients have Medicaid. And I say to them, I'm going to do this, and we're going to do these like sort of more risky things, but reasonable things so that you can hopefully be a mom. But can you do IVF? And they're like, I can't pay my bills. Like, I don't know how I'm ever going to afford this thing. And what I worry about is withholding that care from them because it just feels like a waste of time. And I think it's really important that we challenge ourselves to continue to have these conversations with our patients, and because it's really up to them whether they can afford it or not. But it's up to us from a policy and advocacy standpoint to try to help them get the care they need to actually fully see that to fruition. And failure to do so may be considered medical malpractice. So just understand that if you see a patient and you just feel like it's just a lost battle and you don't talk to them about these things, some people consider that to be malpractice. So it's very important that we do address these things with patients. So just some facts: rates of cancer in young people are on the rise. And improvements in care, which have been profound the last couple of years, mean people are living longer, healthier survivorships. And people are delaying childbearing. So, crazy people like me wait till they're like mid to late 30s to do something that is clearly a young woman's game. So the more cancer survivors we have that are going to be faced with daunting reproductive health choices that must be handled expeditiously and carefully. And as cancer experts, we're challenged to advocate for the most fulfilling survivorship available to our patients, which often means parenthood. And that's my 4-year-old. Thank you. Questions?